hear it. Okay. So Bob did a fantastic job letting you guys all know about the background and training. In addition to being the medical director of the emergency department at CMH, I'm also, as an OHSU employee, on the faculty of the OHSU School of Medicine, where I'm an assistant professor and vice chair of the Department of Emergency Medicine at OHSU. At CMH, in addition to being the medical director and just a regular ER doc, I'm also the medical service line chair for the hospital. And all of this sort of started in the year 2000 when I became what was then called an EMT basic. Now it's just called an EMT or an emergency medical technician. But back then the delineation was basic, advanced, intermediate, and paramedic. And they were all different kinds of EMTs. So this picture here is of the New York Presbyterian Hospital EMS service. It's the largest private 911 based EMS service in New York City. And after I moved back to New York, which is where I'm from, when I graduated from college in Washington, DC in 2003, New York Presbyterian was the first place I worked as an EMT in New York, after previously working for our campus EMS at Georgetown University. So as Bob said, after I completed my residency in emergency medicine at NYU, Bellevue Hospital, New York University, I completed extra postgraduate training in clinical research and clinical epidemiology. And I got a master's in epidemiology, and my research focused on older folks. And the fellowship was in geriatric emergency medicine. So I did that at New York Presbyterian, sort of coming full circle to where I started out in New York as an EMT. I've been at CMH as an OHSU employee since July 2015. And here in the county, I first provided EMS supervision for medics, which I did for about 3 years before handing it off to Dr. Berry, who's one of my colleagues. And now I am still physician supervisor for most recently Cannon Beach EMS and police, Seaside Fire, Lewis and Clark, Olney Wilewski, Astoria Fire, and also up at the Clatsop Community College, where they have an EMT course. And they've been working for years on developing a paramedic course, getting closer all the time. So that was just to fill in a couple more blanks about me. Now I'll tell you about common medical emergencies. I use the list that Lila gave me. So there's going to be an absence of slides on actual unconscious people, but it will be no trouble at all to review that as we go through each of these things, which are fairly common and likely that you guys will eventually see if you haven't already. All right, just a quick question. The dinging, that's not someone trying to get my attention, is it? No, it's just Bob.
That is just someone else joining the meeting.
Oh, great. Okay, good. And welcome to you.
And someone asked if the slides will be available to us, and certainly this recording will be available and the slides will be on it.
Yeah, I'm happy to give you the slides, as long as you promise to share your feedback with me. Okay, so I describe all of these conditions from the perspective of what I call a street medic, somebody who is not employed necessarily to provide medical care, but is present and knows what's happening and sort of knows what to do, and has very little equipment with which to do that thing. street medics are usually have at least, I would say a lot of them nowadays have a great foundation of medical knowledge. There have been many situations in recent years where people who are doctors and nurses and medics and EMTs find themselves in positions in the streets where they need to help people. I'm not thinking necessarily of, mass traumatic events, but protests, mass shootings, um, hurricanes, and other natural disasters. Um, my street cred, I guess, as a street medic comes from experiencing in New York City Hurricane Sandy. I was a resident at the time, so I was I was a doctor for several years already, almost completed my residency training when the Hurricane Sandy took out all 3 of the hospitals that I worked in. I worked not only in Bellevue Hospital at that time, but also in NYU Tisch Hospital, which was a private hospital compared to Bellevue being a public or city hospital. And then the Manhattan VA. So the largest VA in New York City. Just lost all power. All of our patients had to be transferred. We essentially didn't have jobs for several weeks or even months for some of us. So we took to the streets, knocked on doors, found people who weren't able to call for help because of loss of power themselves, and just sort of did what we could, depending on what we were able to see, what we were able to hear, information we were able to gather, and the smells we were able to experience, with no diagnostic studies at all. And our treatment and management of those patients focused on achieving safety, protecting them from further injury or harm, and deciding if they needed to get to a place where they needed to be treated more invasively by people who had resources and equipment. So from the list, it's slightly different. The list included bleeding in general, but I just sort of, I said, Bob's probably covered bleeding before, and I don't want to retread his path necessarily. So I narrowed it down just to the atraumatic nosebleed in order to keep this sort of a medical talk rather than a talk about trauma management. So difficulty breathing. The list said asthma, but I really wanted to broaden that because it's really hard to tell if someone's having difficulty breathing. You don't sort of go in there knowing that it's asthma. And you can even be told that it's asthma by someone and they might not be right. So I think it's important to sort of broaden what's called the differential diagnosis before narrowing on a path. And so I add to this choking, which can also present with difficulty breathing. Then the other items on the list were chest pain, vomiting, and fainting. This is just a picture of the dog show. I got this from the Cannon Beach website. So I haven't been, but those dogs look really talented. Okay, so difficulty breathing. Here's a list that I made of a few common reasons why people might have difficulty breathing. And I like to picture myself when I'm doing this talk at one of these events, like the dog show on the beach or something like that. So you're confronted with someone who has difficulty breathing. You go into the situation in your mind, sort of knowing what are the main common causes of someone having difficulty breathing. They could have asthma, or they could have chronic obstructive pulmonary disease. They could be having an allergic reaction. They could have pneumonia, viral or bacterial pneumonia. Maybe they're being treated for it, maybe not, but maybe the exertion that they're experiencing is that they're engaging in some sort of activity that's making it harder for them to breathe because of this baseline condition like pneumonia. Less commonly, that scenario will also be true for people with rarer but chronic pulmonary diseases, things like pulmonary fibrosis. The treatment as a street medic isn't going to change. So you can just sort of you can include all that in the umbrella of pneumonia. And then anxiety is going to be a major cause of difficulty breathing. And that may be increased at some of these events. There's a lot of people around, a lot of noise. And someone could be triggered into having a panic attack. It's hard to know. So knowing what to do about these situations is going to require that we gather some more information. We may hear maybe it's a child or a grown-up who knows that they have asthma. The key is going to be when you present yourself as someone who may be able to help someone who's in distress from having trouble breathing, you want to know more about them. Do you have asthma? Have you experienced this before? Look around and see the environment that the person is in. Are there obvious allergens? Are they underneath a tree that is dripping with pollen? Maybe we can get them away from the tree inside to a place with good air circulation. Are they near a fire where there's lots of smoke or some other source of smoke? Are people around them smoking cigarettes or other things that create smoke? If they do not have an inhaler, you may only need to remove them from these things and then call for help because there isn't going to be much else you can do. I considered putting a slide in recommending against using someone else's inhaler. If someone says like, I'm an asthmatic, or their parents, it's asthma, but I don't have the inhaler, or, it's damaged and it isn't working. And someone nearby is like, I have an inhaler, you can use mine. You really want to be careful as a volunteer who's not employed by some entity to provide medical care. As a volunteer, you'll be protected by Good Samaritan if some harm occurs from the use of this inhaler. But I think, really want to avoid that unless someone's life is in danger and help isn't on the way or anywhere near. The kind of risks that I'm thinking about will include transmission of infectious disease first, and then the failure to identify that the medication someone's offering you to use is not in fact the medication that you want. You may be looking for, in our situation, we're talking about it like a child with asthma who doesn't have an inhaler, you'd be looking for albuterol. And you may be handed some other kind of medication, a long-acting rather than short-acting inhaler, or an inhaler that contains steroids, something like that. Now, again, if the question is life and death, literally, then you may just want to use the inhaler. But hopefully you can call for help, and help will be near. I do believe Cannon Beach carries albuterol, so Cannon Beach EMS, fire, whatever. If they do have an inhaler, and the problem is that they are in such distress that they can't successfully administer their own medication to themselves, then the key for you guys is going to be know how it works. You've got, and I should have had a picture here. I'm not going to draw a picture. I think a lot of you can either Google it or what it looks like. There is a metal cylinder of medication that you insert into a plastic casing. The plastic casing has a mouthpiece on it. Sometimes there's a chamber, a large empty cylinder that you can attach to the mouthpiece that helps distribute the medication more easily. Chamber or not, what you're going to do is take whatever device has the medicine in it and shake it, both to mix it up, because it has settled and it needs to be mixed up, mix it up, and to hear if there's medication in there. It's a liquid medication. If you're not sure if it's got medicine in it or not, you can still try to administer it. One of the problems here is if this person came to this event that you're at with already having a couple of days of progressively worsening trouble breathing under their belt, maybe they've been taking their medications more and they've run out, and that could be part of the problem. But if there's medication, you're going to shake it. Then you're going to prepare the person for the procedure you're going to perform. You don't want to just stick it in their mouth and have them breathe. You want to know that they're going to take deep breaths. They're going to do their best to hold their breath so that the medicine can distribute before they exhale. And then before you administer the medication again, you're going to let them catch their breath again, if they can. Now, remember, this only works if the patient is conscious and breathing. As they become lethargic from lack of oxygen or building up of carbon dioxide, you may not be able to help in this way. But first you will tell them, you're going to take deep breaths. Then we're going to form a seal on the mouthpiece. Then I'm going to give you the medicine and tell you to take a deep breath. And then you're going to hold your breath for as close to 10 seconds as you can. Then you're going to take a few more breaths before we do it again, okay? And then you do those things, but you want to take that second to prep them. Otherwise, if there's very little medication left and you depress it, you may have used the last dose and it may not get anywhere but in their mouth. All right. And then
Gina,
yes, please.
Can you hear me? This is Kathy Bell. I hate to interrupt you, but if you can
Please.
see me on the screen, I'm holding up an inhaler. Will that help you?
Let's see. Let's see. Say some more. Say your name again, because I can only.
Kathleen Bell.
There you go. I see you when you speak. Yes, that is it. There's the metal cylinder inside the plastic container. And you can be able, guys, to read the name of the medication on the metal inhaler part without removing it. The name should be, yes, visible. Thank you, Rafi. Rafi's very grateful, Ms. Bell, for you sharing this picture.
You're welcome.
Now she's holding the inhaler upside down. You can see the medication name there. And that's the mouthpiece staring at us like a periscope. I love it. Very helpful. Good. Questions about helping someone to take their own inhaled medication. Now there's going to be other medications, guys, for asthma, for COPD, for people who chronically have these problems. That are not albuterol. They are not going to be as useful for people having acute difficulty breathing. Some examples of these medications are Advair, other things that come in like a disc. They're inhaled as well. Some of them are powders and some are liquids. But they don't actually have a rapid onset and so aren't necessarily going to be useful for someone who acutely needs rescue inhaler treatment in the moment. All right, that's the asthma COPD section of the trouble breathing. COPD is similar to asthma. You are working with people who have a narrowing of the airways. Their narrow airways make it hard for them both to feel like they can take a deep breath in and also hard for them to expel the air that they have taken in. It's not just a difficulty breathing, but in both cases, there's some narrowing. In chronic obstructive pulmonary disease, unlike asthma, there's going to be more damage to the lungs over time. So once they have oxygen inside them, it's going to be harder for them to gas exchange, to create carbon dioxide, and then to expel the carbon dioxide. So the thing you really want to look out for is what happens when they have had so much trouble breathing that they lose consciousness. And in that situation, you go right into your BLS training. You check to see if they're still breathing on their own. You check to see if they have a pulse. You confirm that they're not responsive by calling out to them. If they don't have a pulse, you're doing CPR. If they aren't breathing on their own, then hopefully there is in your kit somewhere a bag valve device or a mouth valve device so that you can help assist ventilations for them. Another major cause of difficulty breathing can be allergic reaction. Now this, I don't know if this is, not all allergic reactions are going to have trouble breathing. Some of them might feel like they are developing trouble breathing, and some of them may just feel strange and itchy and have a rash. But one of the keys with allergic reaction is your job is to look, observe, and to the best of your ability, determine if the person is sick or not sick. In any case, you're going to want to be calling for help. You want to assess, does it look like they're having trouble breathing? Does it look like they have swelling around their face or in their mouth? Can you hear audible wheezing? This doesn't require that you auscultate the lungs or have any other sort of special device. If you get close to them and you hear them wheezing, then you want to have a higher level of suspicion that they're going to have trouble breathing and could develop anaphylaxis, severe allergic reaction. You'll want to make sure anyone who's having trouble breathing, and it seems from the information available from nearby sources that it could be an allergic reaction, you want to call 911. If you happen to have access to some Benadryl, that is probably the least harmful intervention, especially if the kid or adult doesn't have an EpiPen. Allergic reactions, even severe ones, can happen in people who've never had an allergic reaction before. I'm going to tell you two stories. The first story, very short, and it's not about anyone in our county, but many people, proportionately few, but several people who've received the SARS-CoV-2 COVID vaccine have had severe allergic reactions, and they are people who've had flu shots before and never had a reaction, and who've never had a severe reaction to anything before. They just happen to have a reaction to this mRNA vaccine. Second story, I am a medical student. I'm in Africa. I'm on the beach, and all of a sudden I start to feel itchy. I think, oh, I must have been bit by some sand creature. And so I get myself off the beach and I go into a hut nearby, and I take a look at myself, and I notice that rather than having hives, I seem to have become a hive. One red raised blanching rash that is fairly itchy. And I feel that my throat is starting to shrink. I feel that I also have a rash in my throat. I'm not having any trouble breathing. I immediately took 50 milligrams of Benadryl, and then I walked up and down the beach until I found someone who had some steroids, and I took them, and I felt better. But I don't recommend necessarily that if you have steroids, you give them to people. I'd say the key is going to be the Benadryl because of the side effect profile being really mild. If they have an EpiPen, you can help them administer it. And then certainly, as usual, the main issue is going to be if they look sick or they have symptoms that could lead to worsening illness, like trouble breathing, hearing the wheezing, swollen face, lips, then you call for help immediately. Another thing that could be happening when someone's having trouble breathing is they could be choking on something. They could have eaten a large piece of food, chewed it poorly perhaps, who knows, and then in an attempt to swallow it, accidentally aspirated the food into their trachea or windpipe. So that would be a situation where the patient had an airway obstruction by a foreign body. And this could be partial or complete, and you're going to have to gather some more information in order to determine that, and do it pretty quickly too. Excuse me.
Gina, I have a question.
Mhm.
With the use of Benadryl, do you ever recommend, if they have a Pepcid AC or that type of a medication, to take that along with the Benadryl if they don't seem to be getting a relief? And also, if you don't have access to medical care right away while you're out
Yeah.
where we are pretty rural, what
Yeah.
would you say about that?
I say that is a brilliant idea that I'd wish I'd thought to tell you myself. So if you're really waiting to get help, then you kind of have to do everything you can. And everything you can do includes any kind of antihistamine. So there are going to be 3 kinds of antihistamine. If a person can swallow, there are going to be 3 types of antihistamine that you can give them. The most useful is going to be Benadryl because it's very strong. The other 2 kinds of antihistamine you can give are the ones we take to suppress acid release in our stomach, and that's going to be Pepcid or famotidine, and regular, like, non-drowsy allergy medications. So if you've got like a Claritin or a Zyrtec or an Allegra or generic versions of those things, I would say you could pick one from each class and give all of them at once. If you had 50 of Benadryl in your pocket and 20 of Pepcid and 10 of Claritin, and they can swallow, give them all.
Thank you so much for addressing that. Thank you.
Yeah, thanks for bringing it up. It's a great point. We give those things in the ER, not because the proof that they work is strong, but because we have them and there's no proof that there's benefit from withholding them either. And so, that's sort of, it's a kitchen sink situation. Having said
Thank
that,
you.
if you really are rural and you do have some prednisone or something from some other thing, and the patient has facial swelling and you hear audible wheezing and they can't breathe, the very next thing that's going to happen is they're going to go into respiratory failure. So if they can still swallow and you have some prednisone, I would say give it. That's what worked for me when I was wandering the beach in Africa. I never had another allergic reaction again. Never had one before, never had one since. Total mystery. I was on the trip with the director of the New York City Poison Control Center. It was, part of my medical school research. And he told me that in his expert opinion, it was the sun. I was allergic to the sun. And I'm still not sure if he was kidding or not. Okay, so we're looking at foreign body airway obstruction, which can be partial or complete. And I mentioned that you'll have to gather some more information to determine if it's partial or complete, and that's easily done. When you are presented with someone who has an airway obstruction, you have to know that your approach changes if the patient is able to cough, and it changes if they not only are unable to cough, but then lose consciousness. And your efforts to assist the conscious victim are going to focus on active and forceful expulsion of air from their lungs to clear the obstruction. Push it out from below. If they can cough, then it's a partial obstruction and you just tell them to cough their hearts out. This is American Red Cross. This is from Mayo Clinic. It's the 5 and 5. So it's not just the Heimlich, but it's forceful assistance in getting air to clear from their lungs through their mouth by giving them back blows, followed by the Heimlich, which is abdominal thrusts. Now, this is what we'll do. I would say in someone who's able to cough, I will sometimes also assist them with a back blow, especially if I think they have a weak cough. I want each cough to be a purposeful attempt to remove the obstruction. And if I look at someone coughing and they are not forcefully coughing, I might just get in there and do some back blows and really help them with their breathing. They can breathe a little bit past the obstruction, and then with their exhale, I'm giving a back blow. And when they cannot cough, then this can be your go-to. Some people may skip right to abdominal thrusts, which is known as the Heimlich maneuver, which you can see here in this picture. You're forming a fist, and then you're cupping your fist in your other hand, and you're aiming under their rib cage, but you're using a J motion with your hands to push from their abdomen up on their lungs. And that's the goal, is to expel the air from both of the lungs at the same time, and all of the pressure from that air hopefully clears that obstruction from out of the trachea where it is lodged. What do we do if we can't push on the belly? If they're pregnant, or we can't get a good purchase on the belly, maybe the belly is bigger than our arms. Your hands can go above the belly to a narrower portion of the patient's body, which is their chest. In a pregnant woman, it's helpful if you try to get under the breasts rather than compressing over the breasts. You'll get lower in that case, so you'll get more air from the lungs. And the presence of the breasts, if it's within your grasp, it can actually restrict your ability to compress the chest by being sort of too much cushion, as it were. Well, these are all grown-ups. So what do we do for the baby? So if a baby is choking and not coughing, not breathing, but awake, we're going to support their whole body with our arm, hand on our leg, sitting in a chair, hopefully, rather than standing up, or perhaps kneeling on the ground on one knee to support ourselves. And then we're giving back blows, each with enough force to hopefully, the goal of which is to expel the lodged obstruction. So, you know, it's hard to gauge how much force to use, but the key is going to be, it has to at least be enough to make them lose their breath, because that's sort of what you're doing. One thing you can't see here, but everyone who's been through BLS training will know, what we're doing is holding the bony part of the baby's jaw with our thumb and our forefinger. So their jaw is sort of in the space between our thumb and our index finger. And we're not pushing on the throat. We're not pushing up on the soft tissue, which, you know, is where their tongue goes. So the base of their tongue could obstruct their airway because they have such narrow airways, such large tongues. And this, for this reason, is why while we're delivering the back blows, the baby is leaning forward instead of sort of being in a different position. This helps the tongue to fall forward and the other large soft tissues that could be contributing to the narrowed airway. Another reason why someone might be choking or have trouble breathing isn't an airway obstruction, but an esophageal obstruction. So same scenario, someone's had a big piece of street meat or whatever, and they haven't chewed it well, or maybe they did, but maybe they have a narrow esophagus anyway from acid reflux for many years or some other reason. The people who have the obstruction, not in their airway, but in their esophagus, are going to have slightly different symptoms. They will be able to breathe. They may feel like they can't breathe, but they'll be able to speak. They'll be able to tell you, oh, I don't feel like I can breathe well, or it feels like there's something in my throat and I just swallowed and I can feel it right here. They may be drooling. And even if they're not drooling, there may be a situation where they're regurgitating their own saliva several minutes after swallowing it, 30 seconds, 2 minutes, some small amount of time. If they attempt to eat or drink something in order to help push past the obstruction, they may find that they are not vomiting, but simply regurgitating the food and drink that they are trying to eat. What we want to do in a case of esophageal obstruction is encourage the person to relax as much as possible. And we know that it's difficult when someone is experiencing something that's scary or someone is anxious to get them to relax. It's certainly harder than saying, relax. If you don't relax, it'll just make it worse. So what we want to do is think of ways to encourage people to relax that don't make them more anxious. We can do that by decreasing external stimulation. If they're in a crowded area where there are lots of people around, help them move to a different area, quieter, calmer, provide them with reassurance. Help is on the way. You know, listen to me and I will do what I can to help you, and we can, you know, increase your comfort level. You can also talk through breathing with them. Since they have an esophageal rather than an airway obstruction, they are able to breathe. So they should endeavor to do so adequately. So we don't want them to start hyperventilating, and we don't want them to hold their breath and try and bear down or anything like that, because none of that is going to help. The breathing method that I like to give to people, I think is universally helpful for any kind of non-airway related difficulty breathing. I do boxed breathing. So I encourage someone to exhale all of their air and then take a deep breath. I like to say, take a deep breath for 4 seconds and then hold your breath for 4 seconds and release it for 4 seconds. Then hold your breath for 4 seconds again. People who are very anxious really can't make it 4 seconds. So I would say start with however many seconds that they can do. 2, 3, that's fine. That's 4. That's 4. 4 is nice if you can get to it. And you may find if they can hold their breath longer, then they may start to calm down. And as they relax, their involuntary muscles may relax more easily too. The sphincters that are acting up may relax if they can calm, focus on their breathing, and just sort of relax, tell them to relax all of the muscles that they can. It helps if they're in a seated position so that they don't pass out. Another thing you can do, if they're able to take instruction, even though they're regurgitating, you can find a carbonated beverage and have them take very small sips of the carbonated beverage. And some people have had really good response, of even avoided going into surgery if you just have a Pepsi on hand or a Coca-Cola. Anything to add, Dr. Wayne, about treating esophageal obstruction without going into the OR? Any thoughts or pearls? Glucagon? All right.
So this is Bob Carolla. This is a problem that I have personally with the esophageal stenosis. And first of all, the most important thing for me is to make sure and focus on chewing my food so I don't swallow large boluses.
Sure.
Some people have talked about sipping warm liquids that might help your esophagus relax.
Yeah.
Not sure I've had that be successful, but just thought I'd mention it.
I like that too. You can try if you, especially you don't see a carbonated beverage around, but someone's got like a hot chocolate stand or something, might be worth a try. I'm thinking of all of this again, like I'm imagining myself at some fair in Cannon Beach. That's why I keep mentioning. Make sure that you position the warm liquid and the carbonated beverage stand near the hot dog stand. Okay, another reason someone might have, and again, like this, I'm not saying I think there are a lot of inhaled toxins around fun Cannon Beach community events, but I do, and I don't want to be a downer, but as an emergency doctor and sort of a disaster medicine specialist, I always have in the back of my mind, you know, what is the worst thing that could happen in the space that I'm in right now to the people I'm sharing this space with and myself. And I have been in situations where there were many people who suddenly couldn't breathe. And the reason it turned out was because someone had released some kind of bear spray or pepper spray into the vicinity. So if you identify that this is a situation that's happening, which can be difficult, but it'll depend on, are there more, maybe there are more than one people having trouble breathing all in the same space at the same time. And maybe people also you see are having tearing from their eyes or blinking or have their eyes squeezed shut. Some of these sprays and toxins are eye irritants. And if they get on the mucous membranes of the eye, even if they don't damage the eye, they can cause a great deal of irritation. So your role is going to be, first, as always, protect yourself from being exposed, but also guide people to a different space, guide them to an open space, loosen restrictive clothing. Maybe someone's wearing a tie or has something tight around their neck. You'll want to loosen that. If they have a very tight shirt, give it a good stretch. And then think about the possibility that this person who's having difficulty breathing, like from any other reason of having difficulty breathing, they may not be getting enough oxygen to their brain, or they may be having a buildup of carbon dioxide from an inability to exhale well. Encourage them to be in a sitting position in case they faint. When someone's having a trouble breathing, you want to make sure that they have a supported chest. You want to avoid hunching over. Anything that decreases the amount of space in their thoracic cavity could make it more difficult for them to breathe physically. Interlude, fat bikes on the beach. Someone's having chest pain. Okay, so we're moving from someone's having difficulty breathing to someone is, you notice that someone is saying that they are having chest pain or chest discomfort or chest pressure. Often it's not going to be a pain that they feel, but some other thing, strangeness. I'm going to say a few of those things are not even painful. Some of the things we consider equivalent to chest pain in certain situations are going to be lightheadedness or dizziness, an abdominal pain and nausea, a queasiness. Someone could have pain or pressure not in their chest, but in their shoulder or their neck or their jaw, shoulder, arm, neck, jaw. The people who classically have chest pressure are going to be men. So other types of people have sometimes some different and maybe even strange symptoms. And that group is women, diabetics, and older adults. So if someone's experiencing some symptom and you have an instinct that something is really wrong with this person based on how they look, just call 911 immediately, call for help however you do. If you're in a place that has an AED, get it or send someone else to get it. Get it before you need it so that it is there already when you need it. And then get that person who's complaining of that symptom to a safe place with a firm surface. Get swimmers out of the water, dry them off. If someone's climbing something, get them down. Get them in a chair or somewhere where if they pass out, maybe from a heart attack and have a cardiac arrest, then somewhere you can be able to do CPR and apply the pads of an AED. Now, if the patient or the person is still awake and able to talk to you, you can, get some information from them about their pain. Where is it? When did it start? How long have you had it? If you've got some aspirin on hand, I would say almost every reason someone has chest pain, it's safe to give them aspirin unless they have a history of anaphylactic allergic response to aspirin. If the person tells you that they aren't supposed to take aspirin because they are on blood thinners for some other reason, maybe they have a history of a DVT, a pulmonary embolus, or they have atrial fibrillation and they're on stroke prophylaxis, you can tell them it's okay one time for heart protective purposes to take these 4 baby aspirin right now and chew them. It won't interact with your blood thinners the way it would if you were taking like long-term NSAIDs. They're still protective for that group of people. Questions about chest pain? Has anyone ever been in a public community scenario where someone seemed like they were having a heart attack? What did I miss that people should be aware of? Pearls.
Gina, this is Kathleen again. And just, you talked about nausea, but there may be vomiting associated with this. So there's always a risk of aspiration. So I would add to your thing, if there is nausea, prepare for vomiting and be aware that aspiration can happen because the person may be losing consciousness.
Absolutely. That's a great point. So in any situation where someone's vomiting, hopefully they're able to sit upright and hold their own stance, in which case you want to give them some kind of receptacle to contain their vomit. And a direction you should be allowing them to vomit downwards. A problem would occur is if someone is too weak to sit up or stand, then you're going to want them to be in a lateral recumbent position on the ground. Lateral recumbent meaning pick a side, left side or right side, and then have them lying down with the side of their face downward, but their head angled toward the ground downward, so that instead of aspirating the vomit, we can clear it as best we can from their mouth and airway. Great point. Speaking of nausea and vomiting, if the symptom is nausea and vomiting, that's sort of the main symptom, and it's not accompanied necessarily by other things, you're going to want to try and gather some more information to help you decide what you can do to support the person who's experiencing these symptoms. You want to know potentially, is it a pregnant woman? Are they experiencing abdominal pain as well? If someone has nausea and vomiting and one of the issues they're having is abdominal pain, there could be a very dangerous emergency occurring. Is the patient diabetic? Then nausea and vomiting could be a sign that their blood sugar is high. I have a note here to contain the emesis when possible. One of the major causes pre-COVID pandemic, major cause of nausea and vomiting is viral gastritis, viral gastroenteritis, if accompanied by diarrhea. So when people are expelling the vomit, when they're vomiting, then there's a chance that this virus that other people could be exposed to whatever virus is causing their nausea and vomiting. So you'll want to protect yourself by limiting your exposure to that event. Your ability to treat nausea and vomiting is going to be really limited. And I think the most important point is not what's on this slide, but what Kathleen mentioned about protecting the patient's airway, the victim's airway, making sure they're not aspirating their own vomit. That could lead to several days from this event. If they aspirated, that could lead to a pneumonia that can be difficult to treat.
So Gina, from personal experience, when you turn them on the side, if you turn them on the side so they face you, they vomit on you. So I always say be careful because you're
get behind them.
Yeah, I've been vomited on more than once.
I'm sure.
Definitely turn them. Be aware of that. Yeah, sure.
Yeah, it's true. You're gonna want to think like what is the best way that we can get this person on their side on the ground, facing away from other people. And the part of the goal is going to be behind them. So you're not always going to be able to achieve the goal. You just do your best. Fainting. I feel like fainting is probably the biggest topic. It is the broadest. It has the broadest differential diagnosis, the most contributing factors to any of the topics, in this talk, of the common medical emergencies. And it can be very difficult to figure out, sometimes impossible to figure out what is contributing, what caused the fainting episode. So some common contributing factors to fainting episodes: people getting overheated, people who are dehydrated, people with low blood sugar, hypoglycemia, pregnant women are at increased risk of having fainting episodes, and people who are compromised by some kind of intoxicant, especially true if several of these things are happening all at once. Then there's going to be the thankfully rarer situation where the fainting episode is caused by something that is truly dangerous. So here, the first thing, overheating, because again, we're at the bike race on Cannon Beach, and I don't know, it never gets that hot, does it? But it can be very hot. And people can overheat even when it's not hot, especially locals. When we are acclimated to the weather of the Pacific Northwest, then it doesn't have to be as hot for us to have heat exhaustion or a heat stroke than it would be for someone who is in a different place that has hotter weather or is more frequently hot. So the people at the most risk are going to be older folks whose, as we age, our physiology in general changes, outside of our control, and we have fewer reserves physiologically, both with breathing, with muscle strength, ability to tolerate dehydration and lack of nutrition. All of that sort of weakens. Children also, children rely on adults sometimes to remind them to eat and drink, to remind them to take it easy, to protect themselves from exposure to the sun. So with their high activity levels, high energy, they're burning a lot of calories and, creating a lot of heat. Another group with very similar is athletes. You can think of, if you've had like a marathon or even a half marathon. I think once we did have someone even with a much shorter distance, like a 10K. I would say with the Columbia crossing, we get someone in the ER every year who has fainted right at the top. And contributing factors include dehydration and overheating. Another group of people, even though they're not participating maybe in quite so vigorous an activity as running a marathon, people who are working outdoors, construction work in the summer. You have to be especially careful of overheating, especially when you're at a height. There's a great risk of falling from a height, from a ladder, from a roof. So, and there are some groups of people who are so dedicated to the task that they are doing and so distracted by the importance of their task that it can be hard for them to remind themselves to eat and drink. Sometimes I will get people who come in overheated, have palpitations, are flushed, hearts racing, they're confused and lethargic, and a contributing factor may be because instead of drinking water during the day, all they had to drink was their morning coffee and then a few caffeinated beverages throughout the course of the day. Soda isn't water. It doesn't hydrate. We need to remind people, because the most important way to treat heat stroke and heat exhaustion is to prevent it. Make sure there's plenty of water at our events. Maybe access to like a hose or a shower if we need to cool people down. Encourage people not to drink too much alcohol, caffeine, and then of course, the remembering that the temperature inside a car or some other closed vehicle is always much higher than outside where there's air circulating. So we have to set limits for ourselves and our neighbors, and then be ready to identify overheating when we see it. And I mentioned dry, hot skin already. There will be people who are sweating profusely, and then there'll be people who can't sweat anymore. They don't have any liquid left to sweat. So there's no way for them to cool themselves, and that's very dangerous. And then again, here's going to be another reason why someone might have nausea and vomiting. And here's just a fun, as an EMT, we always asked ourselves, is it heat exhaustion or heat stroke? Because the treatment is slightly different. The way you can intervene and protect the victim is going to be slightly different. If they're just experiencing heat exhaustion, they're still sweating, and they may have cramps, they may have nausea and vomiting, they may feel faint, and that's going to be, those are going to be reassuring signs. If someone is not having sweating anymore, their skin is very hot, maybe they've even lost consciousness, then we just have to make sure that we've called for help, and we have to find ourselves some ice packs or a hose attached to cool water or something like that. And really start cooling their skin down for them, because they have lost their ability to do it themselves. And the key, if they've lost consciousness, then is pulse checks, breathing checks, and checking in with them. Maybe they are in and out of consciousness, and that is reassuring sign that you do not need to start CPR. Another cause of fainting can be low blood sugar. And cause, every time I say cause, I mean also contributing factor, because like I said, a lot of these things can happen all at the same time. Here's some symptoms of low blood sugar. You'll notice that they look a lot like symptoms of other things. And it might be difficult to figure out that low blood sugar is the cause of someone's symptoms, unless you already have it on your mind as a possibility. One of the most common signs of early or mild low blood sugar is shakiness. The person will feel, and this is someone who doesn't have tremors usually, they will feel like they're tremulous or have difficulty controlling their fine motor skills, and can be confused about it, because confusion is also a symptom, even of mild hypoglycemia. They can break out in a sweat. They can feel lightheaded or dizzy. They can start to feel a little anxious, just like someone who's dehydrated. They may have palpitations. They may have a headache. When someone is having symptoms like this and you are observing that they need help, you're going to want to have an idea of what red flag symptoms you should notice as they happen. Does the person have muscle weakness? Are they having trouble holding themselves up, standing, even sitting? Has their speech become slurred? Are they reporting having blurred or double vision? Do they look like they're becoming very sleepy? There's a spectrum of consciousness from lethargy all the way to unconsciousness, and steps in between include people falling asleep in the middle of a conversation, people falling asleep unless you're talking to them, and then as soon as you stop talking to them, they drift off again. And people with severely low blood sugar, their brain can no longer keep them awake because it requires glucose in order to function. Severe hypoglycemia then can also lead to convulsions or seizures. It can be confusing because a lot of you might experience some of these symptoms from some other condition as well. And if you don't have a glucometer in order to measure someone's blood sugar, how will you know what's happening if someone is having slurred speech, double vision, muscle weakness, and then they start to seize and lose unconsciousness? A quick note, because in the list that Lila sent me, they mentioned high blood sugar. There is relatively little you can do about high blood sugar. As an EMT, I remember I was trained, someone has a sugar problem. It doesn't matter if it's low or high, you give them glucose until you know what their sugar level is. There's nothing you can do, you just give them glucose. If it makes them better, then they had low blood sugar. And if it doesn't, then they had high blood sugar. I don't necessarily think that was a great way for me to be trained or to train other EMTs, but there are some things you can look for. People with high blood sugar might have a fast respiratory rate. They might, even if they don't feel short of breath, they may be breathing really quickly. And that's part of the body's effort to combat the metabolic changes that occur when the blood sugar is too high. It changes the pH of the blood. So we try to increase our respiratory rate and breathe deeply to expel more carbon dioxide, to get rid of the acid in our blood. When some diabetics who don't have insulin are developing severely high blood sugar, they may create ketone molecules. The presence of ketones can be detected by some people. There's an odor that has been described as like a sickly sweet or fruity sweet smelling breath. I have never smelled that in a diabetic. I've had diabetic patients with blood sugars that you wouldn't believe, 500, 800, 1200 when measured in the emergency department. But I have never smelled the ketone smell except in one person in my life. I had a friend in college who was on a special diet where he only ate meat. I think now they call it the keto diet. And it's a terrible, terrible way to poorly nourish yourself. And it creates the body, it fools the body into thinking that it's starving. And that is what creates the ketones. They're called starvation molecules. And this is what happens also when diabetics have very high blood sugar. That cannot be, broken down. Is the body creates these ketone molecules that some people can smell, but not me. People with high blood sugar, they might feel very dry. They might be very thirsty. You may get them to say, oh, I've been drinking tons of water. I couldn't possibly be dehydrated. Or I'm peeing all the time. Maybe it's a urinary tract infection or whatever, but really it's high blood sugar. And your body's trying to get you to drink more by increasing your thirst. And it's trying to get rid of the sugar in your urine by making you pee more. And you just can't keep up. Some of the symptoms are going to be, like I said, very similar to low blood sugar: nausea and vomiting, confusion. I don't think hypoglycemics experience a great deal of abdominal pain, so that could be something that differentiates, but confusion certainly is a shared symptom between the two conditions. The only tool that you have to combat high blood sugar is water. And you can only give water to someone who is awake and can swallow safely. So that's, you're really limited in your ability to resuscitate someone who is hyperglycemic. I recommend against you administering your own insulin, unless you have a glucometer as well, and you know how high the blood sugar is. when I was during Hurricane Sandy, I had my own glucometer and I took it on house visits with myself. And the way I calibrated it before I measured my patients, they weren't really my patients because I was just a volunteer. The way I measured a person's blood sugar was first I checked my own to make sure that it was correct. And then I checked the person's blood sugar. Otherwise, you can have a glucometer that doesn't work, and then your actions are based on faulty information. It's almost safer to be a street medic with absolutely no tools at all. Just the skills and your ability to recognize just by seeing, hearing, and smelling. Okay, fainting. So fainting is a fainting episode is a syncopal episode. So syncope has, so this is a very short list. It is all the causes and contributing factors of syncopal episodes are much, much more and longer than this. It's 10:44. Oh crap. Really, let me take a pause really quickly and say, should I stop or keep going? I've went over my time significantly.
Yeah, I think it's that you're doing a fabulous job of explaining, I think, the basics of some very complex things. But the truth of the matter is that several of us have other meetings to go to starting at 11.
Sure.
So I don't know how some people have to leave the meeting and they can check in and get the video later on. But I think you should continue with, there'll be lots of them that can stay. So
I can continue to the end, even if no one's here, right? And it can keep recording. Right?
Yeah, exactly.
That way people can watch the rest of it later. And gosh, I'm so sorry. Like I said, I can't see anything, including a clock, and I didn't set a timer for myself. I apologize. All of your time is very valuable. And I'd lost track of time, so I'm sorry.
Well, there are other events that are dovetailed into this today. Unfortunately, I wish we could just have it go on for another hour or so. So just continue on as you are.
You guys would all have fainting episodes from. Yeah. I didn't list boredom here, but it's a factor. All right, so I'm gonna continue just to complete the recording. Yeah. Okay.
Yeah.
All right. Thank you all. Okay, so some major common causes of syncopal episodes. I think of these as a spectrum from okay, manageable to, I have to worry and I have to do something, and oh my goodness, I need help. This is really bad. The worse than bad situations, these causes of syncope are very rare. These are not going to be the most common causes of syncopal episodes. So you can think about, is the patient hypotensive because they lost blood, because they became overheated, they had a vasovagal episode, which I can describe in another slide coming up. They're dehydrated, all those reasons. Then it is the person having fainting episode because they have dysregulated temperature. Maybe they have become too cold. They slept outside overnight. People on camping trips, I think of. Then hypoxemia. Another reason someone could have a fainting episode is not actually fainting, but we could be missing something else like a seizure. Or perhaps the patient's experiencing an infectious disease that has spread to the blood, and now they are in shock. They're in what's called septic shock from a bad infection that could cause people to faint or lose consciousness. Examples of infections that can do that are undetected urinary tract infections, pneumonias, viral illnesses, and then abdominal illnesses. You can become septic from a gallbladder infection that maybe you thought was GERD, and you had a little bit of abdominal pain, your upper abdomen, and you ignored it, and then it became a lot of pain, and then it sort of got out of hand and spread and developed into sepsis. Some much rarer causes of fainting episodes are going to be MI, so myocardial infarction, that's a heart attack. Dysrhythmia, that's an abnormal heart rhythm. And the key there is if the rhythm isn't adequate to sustain normal heart beating, then you're not going to be able to circulate blood and perfuse parts of your body like your brain, and that's going to lead to fainting episode. And then other terrible reasons of syncope are going to be a stroke. It's not very common for a stroke to present with a fainting episode, but it can happen just like it can with an MI. And then hemorrhage, either hemorrhagic stroke in someone, for instance, who has a history of hypertension, uncontrolled hypertension, someone who has a spontaneous aneurysmal bleed in their brain, that assault on the brain can lead to a syncopal episode. Your tool as a street medic is to look at someone who has fainted. If they're awake again, you determine if they have one of the bad things. Did you have chest pain? How did you feel right before you passed out? You also do a 3-part test to quickly determine if they're having a stroke or not. It's called a Cincinnati pre-hospital stroke scale. The components are facial droop, arm drift, and speech. So for facial droop, you're going to look at their face and inspect it when they have no expression, and then you ask them to smile or grimace or something to show their teeth or their dentures. And you will notice that one side of their mouth does not grimace or smile. The one face is normal and one face does not smile. And when you see that asymmetry, then you say this person has facial droop. That's one test. The second test, arm drift. It's not just any arm drift, but it's a pronator drift. So you can see in this picture on the left, our neighbor here, our victim of a fainting episode, has her arms extended. She's not supporting them with her body. They're extended into the air, palms facing upward. Then you ask her to close her eyes. With her eyes closed, her right hand drifts forward, it pronates and lowers. And that is a sign of asymmetric motor strength and increases the likelihood that someone's having a stroke. The final trick, the final test is to test the speech. You have the person say, to repeat after me, you can't teach an old dog new tricks. And you observe what kind of speech pattern they have. They may say the words, but slurred, like someone would if they were intoxicated. They may use the wrong words and can often seem confused about why the wrong word came out of their mouth. Or they may be unable to say it at all. And an abnormal finding to this test also means increased likelihood that the person is having a stroke. All right, thank you. Okay. So let's say the Cincinnati pre-hospital is normal, or it's equivocal. You're not sure if it's normal or not. Is the person having a stroke, or is something else going on? We need more information. Hopefully they can talk and you can ask them. If they are not able to talk, then maybe they're at this event with someone else, and you can get some information from a friend or a family member. What happened? When did it start? The last time this person was appearing and acting normally is one of the most important pieces of information that we can have, because within a certain time window, if someone's having a stroke, some intervention could prevent actual lasting damage. Interventions include going to an ER and having a clot busting medication, a thrombolytic or a fibrinolytic. That has to occur within 4 to 6 hours of a stroke. I can hear my baby crying in the background. Another time window that's important is the 24 hours. 24 hours from onset of the stroke. This person was last normal 24 hours ago. If imaging in the emergency department shows an obvious source of clot in the cerebrovascular, in the blood vessels in the brain, A higher level of care like a OHSU or a Legacy or a Providence will have access to interventional neurologists and radiologists who can actually do what's called a thrombectomy and pluck the clot out by using some minimally invasive vascular procedure. So it's very important to know, how long has this been going on? When was this person last behaving normally? Do they have a history of having this happen? Maybe they have a history of a stroke, or maybe they faint a lot and they wake up and they're like, I faint all the time, don't worry about it. Maybe they have epilepsy. Other questions you want to know are, did the person have a traumatic event? When they lost consciousness, you'll want to note, did they actually hurt themselves on the way down or not? Because you may have other considerations for a trauma patient who had a syncopal episode. Is the person on medications that can shed light on why this happened? Are they on antiplatelets like aspirin or Plavix? Or are they on blood thinners like Xarelto, Pradaxa, Apixaban, Eliquis, warfarin, Coumadin? Or are they intoxicated? Alcohol is going to be more likely than other intoxicants to simply cause like a loss of consciousness, but really other intoxicants can do it as well. Okay, I mentioned vasovagal syncope before as a cause of fainting episodes. It can be confusing when someone faints. We, in the emergency department, when we get a person whose chief complaint is they had a fainting episode, one of our first thoughts is, was it syncope or seizure? First, we rule out a stroke, and then we decide, did they faint or did they have a seizure? How are the two things related? Why can't we tell right away? Victims of vasovagal syncope and people having a seizure, most often they have what's called a prodrome. They feel it coming. They feel like they're going to faint. Or someone with epilepsy is like, oh, I felt my seizure coming on, in the way that it does, however that is, and that can vary. Then both victims will lose consciousness, or even if you can't tell if they're awake, they will not be responding, not to your voice and not to, pinching or whatever other kind of noxious stimulus you might employ to see if they are awake. And then people who are having vasovagal syncope episodes can have convulsions and not technically be having a seizure. How are they different? How can we tell the difference so that we can know how to treat one versus the other? People having a vasovagal syncopal episode will be pale. They will be diaphoretic, so they'll break out in a sweat. And if you check their pulse, it'll be slow. If you have a blood pressure cuff, you'll see that they have a low blood pressure. People having a seizure have lost total control of their muscles. And that includes involuntary muscles, like they're, the muscles that we use to hold in their sphincters, to hold in our urine, to hold in bowel movements. They can become incontinent. They will not be able to breathe. They can't, move their diaphragm. They may be foaming at the mouth. They may have bit their tongue and have blood foam at their mouth. And then finally, when they wake up, they may be confused. They may not be able to answer simple orientation questions like, what's your name and where are we? Whereas someone who wakes up from a fainting episode isn't confused. It may take them a few minutes to wake up, but once they do, they know themselves and they remember where they are. Pearls for managing possible seizures. So you had someone lose consciousness and they were convulsing. I don't know if it was a fainting episode or a seizure, but while it's happening, you want to remove sharp objects that are nearby them. That protects them from harm and injury. You don't want to put anything in their mouth. Keep your spoon or your wooden stick to yourself. Anything you put in their mouth, they can choke on, they can bite, they can break their teeth. You want to do your best to, once they're protected, you want to make a note of the time they started to have a convulsion and then the time that they stopped having a convulsion. That amount of time is going to be one of the first questions that any medical professional asks you, the witness of a seizure, about what you saw. And it will help us determine if the seizure is dangerous or if it's just someone who has a seizure disorder, had a breakthrough seizure, they need to follow up with their neurologist. The key is going to be, did it last for longer than 30 to 60 seconds? Sometimes it feels like a long time. That's why you have to take a look at your clock and mark the time, because you won't accurately be able to say how long the seizure was unless you're actually looking at a clock. And then the key is, did they wake up afterwards or not? So they were confused, fine, but they woke up. That's going to be important, because there's a condition that you can have where you seize and then you don't wake up and you seize again before you wake up. And that's called status epilepticus. And that's a serious medical emergency. Once someone is recovering from their convulsions, you can put them in the lateral recumbent position again so they can recover, and make sure that there is no obstruction to their mouth so that they can breathe, because they weren't breathing during the seizure. All right, and here's my last to address on the list that I got sent to prepare for you guys. It said bleeding. And I know that Bob has talked about packing the wounds. The one thing that's going to be different, the one type of bleeding that's going to be different, is going to be a nosebleed. So the pearl I want to leave you guys with is, the important part of a nosebleed is to lean forward so that blood leaves the nose and doesn't go backwards down the throat. Blood is very unpleasant for the stomach. If you swallow enough blood down your throat, you will throw it up. Throwing up blood can be very confusing, and the violence of that act can, even if you had controlled the bleeding, can start bleeding again. So you want to lean forward, or instruct the person with the nosebleed to lean forward. Tell them to pinch the part of their nose just under the bone. So there you feel for the nasal bridge, the bone, and you slide your fingers to the soft part. This is where most nosebleeds are going to be coming from. There's a bunch of blood vessels right here called the anterior, called the plexus. And that's the bleeding coming from anteriorly in the nose. Some people may have bleeding from further back in the nose. It's going to be very hard for you to control this bleeding. But regardless of where it's coming from, you are feeling for the nasal bridge. You're having them squeeze, or you're squeezing the soft part of the nose just under the bridge, and you're making sure their head is tilted slightly forward and not leaning back. Stuffing the nostrils with paper or gauze will not stop this bleeding. You need to tamponade it on both sides. And that's that. Sandcastle.
So Gina, would you use
Wonderful.
ice on a nosebleed?
You could, external ice. So ice can thicken things, thicken blood and other liquids, and that can help to slow maybe, but it's going to be difficult to apply ice in a way that allows you to also be compressing the nasal bridge, which is going to be the most important thing, is the tamponade action.
Thank
Gina,
you.
I've got to run. I couldn't leave your lecture because it was so good. I was learning stuff myself quite a bit. One little point about breathing that everybody has to remember is, when someone can't breathe, if you sit them up, then you get gravity to help them breathe in. That's the easiest thing you can do for someone who's having difficulty. If they're laying down, their diaphragm can't work the same way. It's just the mechanics. So sit them up, and that'll always help people to breathe a lot. I have a couple of quick questions about what we should be adding to our bags listening to you talk.
Sure.
And I'm really thinking about putting Benadryl in my bag, maybe a face mask of some sort that I can help somebody breathe with. That's not in mine. I don't know, Kathy, you've got to tell me about what you think about these things in another discussion. And I think that we probably ought to also carry Benadryl and aspirin. I mean, those are easy things that, listening to you talk, they're very they're noxious, they're not dangerous, and that you can't lose by giving those things. So I think those are things that lots of us, either medically trained or not, could easily add to our bags. And I'll add that to our discussion later on with Lila pitching in, and Kathy especially. So I got to run. Thank you. That was a spectacular lecture. I think we all agreed. I'll let you go on and answer questions for people, but a lot of us have to go to another emergency preparedness session.
Again,
We're
I'm so
opening up.
sorry.
Yeah, we're opening up some of our centers today. Okay, bye-bye. You carry on, Gina. Thank you. You're fabulous.
Anytime, Bob.
So Gina, this is Lila, and I just wanted to thank you for this. We were going to do this last March, and it actually was, the concept was, we did our first community training. Kathy did one on non-pharmaceutical pain management. And we realized that one of the things our MRC wanted to do is give back to our community by training them in this kind of thing. So thank you so much. And I do have one question that is going to show my age. So back in the day when we were giving, large numbers of measles vaccine in a measles outbreak, we had a child who reacted to the anaphylactically. And the interesting thing was you looked at her in the face and her sinuses started swelling up. You could see them swell.
Wow.
But my real question is back in the day when we were trained about the usage of epinephrine in vaccinations in particular, we were told to administer the epinephrine into the site of the vaccine to reduce the vaccine uptake. And I don't hear that anymore. And then the second thing we were told is if the person actually lost consciousness, to administer it under the tongue, because that's the
Interesting.
So I don't know what to do with that old information.
Yeah. So I'm very happy to, I think I can settle this with some good science. First, the administration of the epinephrine, you want to go under the skin or into some muscle. And no matter where you give it, it's going to be distributed through the body the same way. So you don't need to administer it at the site. You can give it in any muscle. And the muscle that we choose is usually the quadricep because it's large and hard to miss. Many people of different body types are going to have an unmistakable location for their quadricep. So we're more likely to be able to get it in there. And in the ER, we give it either under the skin or in the muscle, but we say in the public, give it in the muscle and pick the quadricep. Fast and easy. And it really doesn't matter where you had the vaccine because it will be distributed to the body the same way, regardless. Then under the tongue, this is very interesting. I like the history of medicine. I like it quite a bit. I had never heard that you would give epinephrine under the tongue, but here's the reason why. So this is a picture of the underside of someone's tongue. You can see this is the bottom lip. This mass of purple blue is blood vessels. And they aren't just capillaries like are in the surface of most layers of our skin, but these are actually veins and, not arteries, but there's an artery nearby. Don't put anything on that. These veins are large enough so that it's like administering medication into someone's arm. If you can get a medication in here. So the key is that the medication has to be able to be absorbed through the surface. So this is going to work for a lot of medications. It's going to work for nitroglycerin tablets. It's going to work for dissolvable nausea medication like Zofran, which is also called ondansetron. We'll tell people to put a lot of these different kinds of medications under their tongue because as it melts, it is absorbed directly into the veins and gets distributed parenterally in that way. I would say don't do that with epinephrine. I would say there's no benefit. The key is going to be if you don't, like, if there's a situation where you have epinephrine but don't have a needle. And I can't imagine why you would be in that situation. Like just, but epinephrine we don't administer intravenously in the ER except in cardiac arrest. So, but I think that's very interesting. You know, obviously people millennia ago noticed that there were blood vessels under our tongue and that it was very easy access. And I'm sure people put a lot of things under their tongue in the past, but we don't do that for epinephrine anymore, not for anaphylaxis. Interesting. Very cool.
Thanks.
Other, anything else? I love.
Mind, Gina? Gina, do you mind if we share this video with other folks?
I think that's fine. Yeah. I hope I didn't say anything embarrassing. I wasn't cursing.
Excellent.
Okay. Yeah, please feel free. I saw a hand go up.
Yeah, I have a question. This is Bob Kroll. I am wondering if you are familiar with and can comment on the use of a device called the Life Vac for clearing an airway obstruction.
Wow.
Okay. Do you know that device?
No, I'm Googling it.
Okay, yeah, it is like a reverse plumber's helper combined with like an ambu bag with a one-way valve in the opposite direction. So you push the plunger in, and then pull back and suction. I've only seen it online.
Wow.
But at least the things I've read about online make it sound like it's as effective or possibly more effective than the Heimlich. And so I just didn't know if that was, you know, I mean, I first saw it on Facebook, and we all know that Facebook is the, you know, the go-to medical resource.
all the true facts are on Facebook, right?
Yep.
This is incredible. I would say I've never heard of it before in my whole life. I think it's very interesting, and it would be relatively easy for me to figure out if scientific research has been performed that confirms that this is helpful and not harmful. I could just search the literature for a few minutes and then get back to you.
What I've seen is that it's not FDA approved, but it is FDA registered.
Oh, wow. Let's take a look at this. Wow. No, I have never heard of that. I couldn't comment on it,
okay.
Whether or not it would be useful.
It's, you know, it's not something that we're all going to carry in our back pockets, but it might be something in a EMT rig.
Yeah, and just my caution about something like that, which looks terrifying, actually, I have to say, is that, you know, from years and years of peds, the people with obstructions are often children. And the first caveat is that you don't do any harm. And so you're attempting to remove the obstruction, but you really, really do not want to increase the problem or push it farther in so that there's no other way to get it out except surgery.
Absolutely right. Agree. Very interesting.
Okay. Well,
thank you.
Thank you very much. There may be other questions, but please read the chats because there are lots of great thank yous to you.
All right, I will read the chats. And then if someone doesn't have another question, I'll start to head out. I can hear my wife calling for me and the baby crying. I'm sure they're fine.
We'll let
Thank you so much, Gina, for your time. Terrific job.
Oh, thanks, guys. Yeah, I'm so glad I got invited to this and to have all of you attending and watching. It was a real pleasure. Thank you for your questions. Awesome questions.
And we will do our best to make the video and the slideshow available.
All right.
To everybody. Okay. And you can send your, you know, PowerPoint to Lila or to me if my email is in the comments above. So.
All right, super.
Thank you very much, Gina.
All right, guys. Goodbye, all.
Bye-bye.
Let's see.
Are you going to go over to